So now we're going to talk about obstructive sleep apnea, OSA. A lot of people have sleep apnea. Not all patients are obese. That can be a factor, but not all patients are obese. So your tongue and palate fall backwards and obstructs the pharynx. Patients basically have 15 to 90-second obstructions on their breathing. So obviously if you're not breathing enough, you're going to be hypercapnic and hypoxic. Risk factors are obesity, age, neck circumference, men that have neck sizes greater than 17 inches. That's more common for them. So these patients awake a lot at night because if you're not getting enough oxygen and have high CO2, you basically, when it opens up, you gasp and you're waking up. So they have horrible sleep patterns. They find themselves being very sleepy during the daytime. Loud snores comes with it. Lots of them complain of morning headaches because of the high CO2. There's some patients that don't have the morning headache, so this obviously affects your personality, irritable, moods. You can develop hypertension. Pulmonary hypertension is a factor for these patients as well because they're not getting enough oxygen and they have high CO2. So we diagnose this by polysomnography. So patients go to a sleep lab, they hook them up, and they find out how many times they stop breathing. So 10 events an hour with oxygen DSAT below 90 is positive. So that is basically how we find out that somebody has it, although probably your spouse or significant other they're sleeping with you could probably tell you you have it just by how many times you're waking up and coughing and gasping. So treatments, well, things you should do that's not very, it's hard to do, is you should avoid sedatives and alcohol before you go to bed. If you're obese, weight loss would help that. There are some oral appliances out there that help. Some people say they help, some people say they do not. The best way is basically CPAP. So 5 to 20 is usually what you set the patient on. CPAP basically is going to keep the airway open on inspiration and expiration. There's something out there called BiPAP as well. BiPAP is basically bi-level. CPAP is continuous. So on BiPAP, you have higher inspiratory and lower expiratory pressures. CPAP, you have the same pressures, expiratory and inspiratory. Opioids, if a patient takes any opioids before sleeping, that could also worsen the condition. There are a couple surgeries out there that some people do. They basically cut off the uvula and trim some of the tissue in the back of the throat. But studies show that some patients that have this done, it still causes, they still have sleep apnea. So probably the easiest treatment, the best one, is doing CPAP. It's just better for the patient. It's easier. You wear the mask. Pulmonary hypertension. The normal pressure in your pulmonary artery is usually 12 to 16. People with pulmonary hypertension have pressures greater than 30, 25 to 30 mean pressures. It's usually, they don't know what causes it. There are other ways that we know that's secondary, so it's usually heart failure or pulmonary disease. Pulmonary hypertension in the primary is incurable. So it basically puts pressure on the right side of the heart because the heart, right ventricle, cannot beat the blood into the lungs because the pressure is too high. So these patients then develop right-sided heart failure. Signs and symptoms, dyspnea on exertion. They're going to diagnose this by trying to rule out every other lung problem there is. These patients usually, though, have right ventricular hypertrophy when they finally seek help. Cor pulmonale, so right-sided heart failure caused by lung hypertension. Treatments, diuretics is a way to do it. Anticoagulation may be needed because if your right ventricle is enlarged, then you could be forming clots in there, and those could go to your lungs. These patients are hypoxic, so that's also going to cause more vasoconstriction. Calcium channel blockers work for some patients, not all. Lung transplant is a way surgically to help this. There are new meds out there that are specifically for pulmonary hypertension. They have a lot of side effects, and they work on different mechanisms involved in the lungs. So cor pulmonale, pulmonary heart disease. One way of having that, as we mentioned, was having heart failure, or also an MI on the right side of the heart can cause that. If it's pulmonary heart disease, cor pulmonale, then it's pulmonary hypertension. So you can have two different kinds of cor pulmonale, right-sided failure by an MI or pulmonary hypertension. So other kinds of things that can cause cor pulmonale are Pickwickian syndrome, kyphoscoliosis, so a scoliosis, extreme obesity. Most common cause, though, is COPD. So you have your enlarged right heart, you have elevated increased neck vein distension, enlarged liver, peripheral edema. Things start backing blood up everywhere. Treatment obviously is to reduce or improve your alveoli ventilation, making the heartbeat stronger, so digitalis, control edema by watching your sodium, helping the patient with diuretics, things of that nature, or the medications that will reduce hypertension, pulmonary hypertension.